So I would like to give you an update in the next 10 minutes of, sorry. My name is Stephan Kemp. I'm from the Academic Medical Center in Amsterdam. And we do both basic science, trying to improve diagnostics, and we do clinical studies. So we do true translational research. And this is, I would like to give you an update on something that we more or less stumbled upon. And I have to give all the credits to Ann Moser for, in March, really telling me that we need to pursue this, because this is really important. Because, to be honest, we had this already for 2 years. It's kind of embarrassing, but anyway. And it's about C26 carnitine, which is a new biomarker for ALD, both in mice and men. So now we get more and more countries going to include ALD for newborn screening. We're now able to identify the patients at birth and clearly give these patients that eventually would develop cerebral ALD or adrenal insufficiency a better outcome. The newborn screening at the moment is done on Bloodspots, and it involves the measurement of C26 lysoPC, which was this method was set up at the Kennedy Krieger Institute by Ann Moser and colleagues. And this is a really powerful measurement, and the only side that the argument for trying to improve this would be that this is a dedicated method. So it involves the newborn screening, and it's a tandem mass spectrometric measurement. It's very powerful. The discrimination between controls and the ALD patients is much better than very long chain fatties by themselves. But there's always room for improvement. But before I go to that, I would like to update you on some of the development in the Netherlands since March of this year. Since 2007, the Netherlands screens for 17 diseases. And in 2013, we were acknowledged that, informed that there were plans to expand the newborn screening program in the Netherlands. And then I was thinking of how did we end up at the right place? But sometimes you just have to be in the right room to be involved, to get the opportunity. So one of the physicians at the Academic Medical Center, he's a board member of the advisory committee of the newborn screening program, and he told us that these plans were undertaken. And he said, "Well, come up, throw in your disease. If so, this is the RUSP list from America, and if your disease is not on there, but you have a very good candidate, then tell me." So we nominated ALD. And they were enthusiastic, and also, of course, there was a lot of data that we could use and that we were allowed to use from the Mayo Clinic, from the Kennedy Krieger Institute. That was not a lot of that was not publicly available, but we were allowed to use that data. And then we were told that there were problems in the Netherlands because in America boys and girls are screened. In the Netherlands, we have the right not to know, and the committee told us that if we would also want to screen girls, baby girls, that we would not have a chance to get ALD in the newborn screening program. So okay, well, we can live with that for the moment. So in September 2013, Mark Engel and I, we gave a presentation for the advisory committee of the Dutch Health Council. And we could see that they were enthusiastic, but then 2014 came and it was very silent. And then in April of this year, we heard that the Dutch Health Council published the new recommendations to the Minister of Health. And that was on April 8th. And within a week, this in Dutch, but within a week, the Minister of Health, she signed the bill. And so technically ALD is now in the newborn screening program in the Netherlands. We have to validate the method, but as soon as we do that, they will start screening babies for ALD in the Netherlands. So we can claim that we are the first country outside the US that screens for ALD. We are really, really happy with that. But as I said a few slides earlier, things can always go better. Well, I'm a translational scientist, so I'm now talking about babies, but now we move back to the mice. Years ago, we have set out to develop a mouse model for ALD, because the mouse model for ALD, it's a knockout mouse. It does not develop the disease. So technically, biochemically, it's a useful mouse, because you can use it for drug screening, if you're interested in the biochemical effect. But if you want to use a mouse model to find out if your drug has any clinical effect, it's not a good mouse model. So we had we have very good rationale for improving the mouse model, and with it summarized on this slide, we use the ABCD knockout mouse, and we in the genome of the mouse we inserted an expression cassette that has the ELOVL1 enzyme. And ELOVL1 is the key enzyme in the synthesis of very long-chain fatty acids. And by breeding these mice with so-called Cree driver mice, we can decide in which tissue, in which cell type, or even at what age this gene is turned on. And by using a mouse Cree driver that is specific for oligodendrocytes and Schwann cells, we generated what we call the ALD 2.0 mouse. And it is an ALD knockout mouse that has activated ELOVL1 expression in its oligodendrocyte and Schwann cells. It really works. It is shown here. First of all, here at the bottom, you see the ELOVL1 protein. We get a nice expression of ELOVL1 protein in the ALD 2.0 mouse. And also biochemically, when we look at the brain and the spinal cord of these mice, and we compare wild type with ABCD1 knockouts and the 2.0 mouse, we see a nice increase in C26 fatty acids. We also looked at LysoPC, which is the newborn screening marker. And that's interesting because LysoPC, if I'm correct, there's only data on C26 LysoPC of blood spots. Well, we do not know if they're elevated in tissues. It's very likely. So we also look at LysoPC, and it's the same. If you look at C24 and C26 in brain and spinal cord, you see again the same color scheme, wild types, knockouts, and 2.0 mouse. We see a nice increase in C26 and C24 LysoPC. And then something happened. A few years ago, it was reported that in patients that do not have peroxisomes, patients with peroxisomal biogenesis disorder, that in plasma, these patients have elevated carnitines. And in that original paper, it was said that LD patients do not have that. But if you really look at the paper correctly, the investigator did not include blood spots from these patients. So we reinvestigated that, and we first did that in our mouse. Again, the same color, the wild type, the knockout, and the 2.0 mouse. And if we look at C24 carnitine and C26 carnitine, we see a very nice increase in the C26 carnitine. And then we figured, okay, so for LysoPC, we went from blood spots to brain. And now we start in brain. So let's look at the C26 carnitine levels in blood spots of mice. So here we compare, here we look at the mice, the C26 LysoPC and the C26 carnitine. So this is what we already know, that C26 LysoPC is elevated in blood spots, but also the C26 carnitine is highly elevated in blood spots. And then we also checked ALD patients. These are AMN patients. So this is what we already know. C26 LysoPC is elevated, but if you look here, the same holds true for C26 carnitine. It's about the same increase. And what is nice is that both the LysoPC and the carnitine, there's a correlation between the levels that we find in blood spots and the levels that we find in brain. So you see here, you see an increase in carnitine and in LysoPC, and we also see that in brain. And the same is true for spinal cord. So there appears to be a correlation between the levels you find in blood spots and the levels that you find in CNS. Is this a biomarker? I don't know, but the future will tell us. So it brings me to the last concluding slides. So we have shown that C26 LysoPC and C26 carnitine are highly elevated in our LD mouse. And that C26 carnitine is also elevated in the mice and in patient blood spots. And that these levels in blood spot correlate with the levels in CNS. And we can conclude that C26 carnitine is a new biomarker for ALD in mice and men. So why are we so enthusiastic about this? Well, first of all, we have to validate this in blood spots from for newborns. But the importance is that many countries screen for other inborn errors of metabolism. A lot of those diseases are mitochondrial diseases. And the way you screen for those diseases is by measuring the carnitine profile. And these are short chain, a medium chain, a long chain carnitines. And the experts tell me, actually, and Moses told me, that why this is so important is that if you screen for long chain, short chain, and medium chain carnitines, you might as well add one extra carnitine, a very long chain carnitine. And that's the C26 carnitine. So within a single measurement, you can include ALD. And we anticipate that those countries that are already screened for mitochondrial diseases, seeing that other countries include ALD, may sooner decide to implement ALD in their own newborn screening program. And this may really result in a faster implementation of ALD in other newborn screening programs. Thank you.
Great. Thanks, Stephan. So, so have you looked at female heterozygotes and what are their carnitines, C26 carnitine?
They are also increased.
Also increased.
Yes, they are also increased. Well, we do need to look at those females that have normal very long chain fatty acids in plasma, because that, of course, is another important issue.
Stephan, very good presented, very good data. I have a question about, have you looked at the carnitine levels in newborns, in a plasma or in any blood spot? Because in adults it may be elevated, but in newborns it may take time to get accumulated and go up in the serum.
It's a very important question. We ourselves have not looked at it because we do not have blood spots from ALD newborns. But the people in New York State and Moser, within 2 weeks, 1 week or 2 weeks after I accidentally told this, they already told me that in ALD newborns it's elevated. At least, and you're, I have seen Moser. I think within a week you already told me that they are elevated.
Yes, New York State is doing a pilot project, and they've added the measurement of C26 carnitine. But time will tell if it's as good an assay as the LysoPC 20.
Absolutely.
Great. Thanks, Stephan.